welcome to Sketchy IM. Oh man, have we got a course for you. This one's got pirates, wizardry, vampires, even. There's a lot of blood in that one. Anyways, probably against someone's better judgment, I'm Ricky J, and I'd like to welcome you to our first unit. Hear ye, hear ye. Ah, sweet. That means the jousting tournament's about to start. Anyways, as I was saying, welcome to cardiology. We're kicking off internal medicine with the heart because it's the most important organ. Well, actually, that's debatable. But a recent meta analysis concluded that it gets cold and stony in the setting of chronic indifference, that it grows fonder in the setting of long term absence, and most importantly, that it likes to break. In this unit, we'll go over just about everything that can go wrong with the heart, from valvular issues to electrical complications and even pressure problems. This chapter, though, is all about blood supply, or the lack thereof, commonly known as ischemic heart disease. Ischemic heart disease, also known as coronary artery disease, is the most common type of cardiovascular disease and the most common cause of death. See why we're starting here? And if there's one place to begin our discussion of ischemic heart disease, it's chest pain. Chest pain is the second most common reason for patients to visit the emergency department, so you'd better get used to evaluating it. The etiologies of chest pain can be life threatening or benign. In the outpatient setting, the most common causes of chest pain are related to GI and musculoskeletal pathologies. So if you come away from this sketch with one lesson, and hopefully you shouldn't, let it be that not all chest pain is cardiac. Alright, let's get this medieval Hastelude tournament underway, starting with the subjective information you can collect for the HPI. First, let's focus on the onset and time course of chest pain. Pain that starts suddenly and is severe at onset is associated with badness. Think aortic dissection, pulmonary embolism, pneumothorax, esophageal rupture, and lands to the chest. The etiologies that present with acute chest pain will be illustrated down here in the jousting yard. Conversely, a gradual onset of chest pain, over a few minutes, with increasing intensity is the classic description of ischemic chest pain. So next to our recurring angina, anvil, which represents the classic pain and pressure symptoms of angina, we've placed a long tapering flag. The etiologies that present with more subacute causes of chest pain will be illustrated up here in the stands, including cardiac ischemia, pericarditis, pneumonia, and GERD. Next up, it's time to ask patients a truly subjective question. What does the pain feel like? Patients often describe the symptoms of acute coronary syndrome, that is, unstable angina, non-ST elevation myocardial infarction, or ST elevation myocardial infarction, as discomfort rather than pain. Often they'll use words like pressure, heaviness, tightness, fullness, crushing, or squeezing. The classic description you'll hear is, "There's an elephant sitting on my chest." And it's sketchy, we think of it as an angina, anvil on their chest. We'll also briefly talk about another cause of angina, and that's vasospastic angina, also known as Prinzmetal's or variant angina. Although it presents similarly to angina due to coronary atherosclerotic disease, it's actually caused by spasms of the smooth muscle layer of one or more coronary arteries. The spasm causes obstruction with decreased blood flow, leading to transient ischemia, which manifests as episodes of anginal chest pain lasting 5 to 15 minutes. If prolonged, this can progress to infarction. An increasingly reported cause of dilated cardiomyopathy is stress-induced cardiomyopathy, also known as Takotsubo cardiomyopathy or broken heart syndrome. As its name suggests, stress-induced cardiomyopathy is typically precipitated by intense emotional stress, and primarily occurs in postmenopausal women. It most commonly presents with ischemic type chest pain. Let's round out our cardiac causes of chest pain by checking out this dude receiving a wicked lance to the chest. That fist grabbing a heart is our recurring symbol for cardiac tamponade. Any cause of pericardial effusion or hemorrhage can lead to subacute cardiac tamponade over days to weeks, with symptoms including dyspnea and chest discomfort. Acute cardiac tamponade, on the other hand, occurs within minutes due to trauma, wall rupture, or dissection. It can manifest as sudden onset chest pain and dyspnea, and promptly leads to death if untreated. Moving on from the heart. If you hear the words ripping or tearing, start worrying. These qualities are classically associated with aortic dissection, as highlighted by this aortic lance tearing as it makes contact with the opponent's chest. One particular type of pain you'll encounter frequently is pleuritic chest pain. Pleuritic chest pain is typically sharp in quality and is worsened by inspiration. Pleuritic chest pain can be caused by all kinds of pathologies, but it's classically associated with pulmonary embolism, pneumothorax, pneumonia, pleuritis, such as in autoimmune diseases like systemic lupus erythematosus, and pericarditis. At Sketchy, pulmonary embolism is represented by a thrombotic nest inside of a pulmonary tree, pneumothorax is represented by a collapsed lung sail, pneumonia with a couple of dirty lung stains, and finally, pericarditis with the red inflamed lining of a heart shaped guitar case. Notice that each of these characters is also wearing a recurring symbol for pleuritic chest pain, a shark tooth necklace. Think of that sharp tooth cutting into the chest as you inspire. And finally, don't forget about the GI tract. GERD symptoms can mimic angina, so it's important to get a detailed description of the pain. The classic heartburn pain is, of course, burning in quality and lasts for a few minutes to a few hours. But the pain can also be more squeezing and angina like. As we'll soon illustrate, the location and radiation of the pain can be similar as well. Expand your differential beyond GERD, by the way, because various esophageal pathologies can present with heartburn symptoms. Esophagitis, for example, mimics GERD, while a hiatal hernia actually causes GERD by impairing the lower esophageal sphincter. One distinguishing feature of esophageal pathologies is that the pain may be persistent and last over an hour. And since we're on the esophagus, another pathology to mention is diffuse esophageal spasm, or DES. This presents with episodic squeezing chest pain that can feel a lot like angina. DES has a few classic triggers, however, which we'll get to shortly. And lastly, to finish up our tour of the esophagus, let's tear a hole in it. Esophageal rupture classically presents with sudden, severe chest pain in the retrosternal area. Speaking of which, that brings us to our next question. Where is your pain? The classic location of ischemic chest pain is substernal or in the left chest. That said, ischemic chest pain is often diffuse and difficult to localize. Hence the diffuse ischemic stains of ash on the angina blacksmith. Remember that inability to point to one spot where the pain is the worst is actually a sign you might be dealing with ischemic chest pain. Ischemic chest pain also classically radiates to the left shoulder, arm, or jaw. In fact, radiation of pain to these areas significantly increases the likelihood that you're dealing with acute coronary syndrome, which includes unstable angina, STEMI, and NSTEMI. Be aware, however, that GERD pain is commonly retrosternal and can also radiate to the back, neck, jaw, or arms. If you get a story of acute, severe, tearing chest pain that radiates to the back, however, think aortic dissection. Lastly, if the chest pain is well localized, that is, if patients can literally point to one spot they're having pain, you're likely dealing with musculoskeletal pain, such as rib fractures or costochondritis. All right, one last set of questions to complete the HPI. Don't forget about provocation and palliation. When it comes to chest pain, this information can be extremely helpful. In patients with underlying coronary artery disease, plaque rupture can occur at any time, causing an acute coronary syndrome with a spontaneous onset of chest pain. Discomfort that's provoked by exertion, on the other hand, is a classic symptom of stable angina. Typically, you might get a story of, I was feeling fine this morning when I started feeling terrible while shoveling the snow off my driveway. Furthermore, if that chest pain abates with rest, you gotta think ischemic chest pain until proven otherwise. The distinguishing feature of vasospastic angina is that the episodes of chest pain occur at rest instead of during exertion. It also classically occurs at night, from about midnight to dawn. As its name suggests, stress induced cardiomyopathy is typically precipitated by intense emotional stress. A classic scenario is a 65-year-old woman who just learned that her son was in a car accident, and she presents with severe left sided chest pain. Pericarditis pain is classically positional, worse when lying supine and relieved somewhat when sitting up and leaning forward. On the other hand, chest pain that reliably occurs, or palliates, with food is suggestive of a GI cause. GERD, for example, may occur after meals or only after certain meals. Symptoms may also be worse at night while the patient is lying down. In fact, heartburn that wakes a patient at night and is relieved by antacids is a diagnostic clue for GERD. Yep, the biggest clue that GERD is the word. the pain resolves with antacid use. Let's tie these more episodic causes of chest pain together in the center of the sketch by drawing in this month's episodic schedule of events. GERD is more likely to occur after meals, angina after exertion, but Prinzmetal angina and diffuse esophageal spasm may cause intermittent or episodic pain with no obvious pattern. Great! Now you have a super detailed description of the patient's chest pain. The next thing to do is widen the lens by asking about associated symptoms, which is usually done during your review of systems. But first, a few details from the patient's demographics may be helpful. Keep in mind that age alone makes certain etiologies more likely than others. For instance, patients over 55 are at higher risk for angina and ACS, whereas anyone younger than 40 should be evaluated for other causes before you think ischemic chest pain. Prinzmetal is more common in women and people younger than age 50, and stress induced cardiomyopathy primarily occurs in postmenopausal women. Alright, now on to the review of systems. Autoimmune disease associated with chest pain may also be associated with systemic signs and symptoms, such as rash, arthralgias, and constitutional symptoms. Speaking of constitutional symptoms, fever raises concern for infectious processes such as pneumonia, mediastinitis from esophageal rupture, inflammatory processes such as pericarditis, or an autoimmune process such as lupus pleuritis. Dyspnea, especially on exertion, is often associated with ischemic chest pain. In fact, it may be the only manifestation in elderly or diabetic patients with ACS. Remember that women, elderly, and diabetic patients can present with atypical signs and symptoms in the setting of cardiac ischemia. Dyspnea, of course, is also associated with pulmonary causes of chest pain, such as PE, pneumothorax, pleuritis, and pneumonia. Check out our acute dyspnea and chronic dyspnea DDX sketches in the pulmonology unit for more info on the conditions that can cause dyspnea. Over in the GI tract, remember that a key distinguishing feature of the esophageal pathologies is that they'll often present with dysphagia or odynophagia. So ask about swallowing difficulty. Finally, preceding leg pain and swelling may be signs of DVT, which can be complicated by pulmonary embolism when a bit of thrombotic material breaks free. Alright, on to past medical history. When ischemic chest pain is on the differential, assess for the typical risk factors for atherosclerosis of the coronary arteries. This includes diabetes, hyperlipidemia, hypertension, and cigarette smoking, among others. Hypertension is also the most important predisposing factor for aortic dissection. Also, if your patient's past medical history includes an inherited collagen disorder like Marfan or Ehlers-Danlos syndrome, aortic dissection should be high up on your list of possibilities. So we've incorporated our recurring Marfan symbol into the dissecting knight's helmet, the Marfan Martian. When it comes to PE, the classic risk factors include prolonged immobilization, recent surgery, and a hypercoagulable state such as malignancy. These factors increase the risk for deep vein thrombosis, which can break off and get stuck in the pulmonary vessels, causing a PE. The prototypical patient who develops primary spontaneous pneumothorax is a tall, thin, previously healthy young man, just like this lanky young jouster here. Notice that he's also holding a pipe to represent smoking, a significant risk factor for primary spontaneous pneumothorax. Secondary spontaneous pneumothorax occurs when there is underlying lung disease. In fact, nearly every lung disease can be complicated by pneumothorax, with COPD being a big one. So we've drawn in our recurring COPD symbol, the blue bloated face mask. The other major cause of pneumothorax is more non-spontaneous and is related to trauma, hence our recurring trauma arm cast. And keeping with the trauma theme here, acute cardiac tamponade is associated with blunt and penetrating trauma to the chest. Hence the trauma cast we've included on this dude getting wrecked by that well-placed lance. That dissecting lance should also remind you that acute tamponade is a frequent complication of type A aortic dissection, which can travel to the heart and involve the pericardium. Invasive procedures, such as cardiac cath, can also cause tamponade, hence the catheter dangling from his shirt there. And finally, don't forget about social history. Cocaine directly causes coronary vasospasm, which can precipitate ACS or Prinzmetal angina. So ask your patient about illicit drug use. Alright, on to the objective findings. First and foremost, check those vital signs. Unstable vital signs, such as low blood pressure, should raise huge red flags that you're dealing with one of the life threatening causes of chest pain. Acute coronary syndrome, aortic dissection, PE, tension pneumo, pericardial tamponade, or esophageal rupture causing mediastinitis. And to help you remember all the life threatening causes of chest pain, we've placed all those characters down in the life threatening jousting arena. The more benign causes are up in the stands. Bunch of ninnies. Obviously, those unstable vital signs need to be addressed immediately before any further workup can be done. Specifically for esophageal perforation, within hours, patients can develop sepsis with fever, tachypnea, tachycardia, cyanosis, and hypotension on physical exam. But on with our exam. Clearly, a cardiac exam should be performed in patients presenting with chest pain. Jugular venous distension can be seen with any etiology that causes right sided heart failure, including MI or PE. JVD is also a part of that classic Beck's triad of signs that accompany cardiac tamponade: hypotension, elevated JVP, and muffled heart sounds. Coincidentally, Beck's triad is also the name of a sick metal band that headlines our cardiac tamponade sketch. Go check it out. Guaranteed to be so frickin' metal. And while you've got your stethoscope out, check for some murmurs, of course. A new murmur is a bad sign, especially in the setting of chest pain, as it may reflect myocardial infarction or aortic dissection. Acute MI, for example, can cause papillary muscle dysfunction, leading to mitral or tricuspid regurg. Aortic dissection can propagate toward the heart and involve the aortic valve, leading to aortic regurg. Finally, listen for additional heart sounds, such as an S3 gallop, which is associated with left sided heart failure, possibly due to ACS. At Sketchy, we represent S3 with our recurring S3 slushy. Plus, it doubles as a reminder of what S3 sounds like. It occurs when fluid enters the left ventricle and hits the residual fluid sitting in there that the ventricle had a hard time ejecting. You'll hear the fluid sloshing in, sloshing in, sloshing in, sloshing in. Also, listen for a pericardial friction rub, which can accompany pericarditis. And you know what? While you're hunched over your patient awkwardly listening to the chest, why not move that stethoscope over to the lungs? Listen for symmetry. Asymmetric breath sounds suggest that you're dealing with a pulmonary etiology. Absent breath sounds on one side are typically associated with pneumothorax. Focal rails or crackles suggest a pulmonary infiltrate typically seen in pneumonia. Or how about pulmonary edema caused by left sided heart failure in the setting of acute MI? Yeah, I went there. At Sketchy, crackles are represented by that snap, crackle, and pop that Velcro makes when it's torn free. Next, slap on some gloves and haphazardly poke your patient's thorax. Increased resonance to percussion on the affected side may indicate pneumothorax. That's air you're tapping on, my friend. Reproducible tenderness on the chest strongly suggests musculoskeletal chest pain, especially if it feels the same as the patient's chief complaint. Also, notice the cool Middle Ages bubble wrap cloaks our ruptured lung and ruptured esophagus characters are wearing. Subcutaneous emphysema feels like crackling or crunching on the chest wall underneath the skin as you press down. Subcutaneous emphysema is associated with pneumothorax and esophageal rupture, though this sign is pretty rare. Feel all the way up the neck, too, because you may even feel some crepitation along the sternocleidomastoid due to the presence of cervical subcutaneous emphysema. Whoa! And it's not just about feeling. You may be able to auscultate mediastinal emphysema if the tear involves the layers of the mediastinum. Finally, don't forget to perform an abdominal exam. Yes, despite the fact that your patient is only reporting chest pain, you're primarily palpating the abdomen for tenderness, which may suggest an abdominal cause of the patient's chest pain. Pain originating from a number of abdominal organs, such as the liver and spleen, can cause referred chest pain. Alright, on to diagnostic testing. Of course, since we're in the ischemic heart disease chapter, you know we're getting an electrocardiogram. A 12-lead ECG is standard practice for virtually everyone presenting to the emergency department with chest pain. The first place your eyes will probably dart to is the ST segment, and rightfully so. Focal ST changes, elevation or depression, are associated with acute coronary syndrome. Vasospastic angina is also associated with ST changes, ST depressions, or even elevations. though these are transient, only occurring at the time of an episode. ECG changes are also common in patients with stress induced cardiomyopathy. ST elevations are common, especially in the anterior precordial leads, kind of like how an ST elevation MI presents. ST depressions may also be found, as well as other changes including QT prolongation, T wave inversion, and abnormal Q waves. The classic ECG finding associated with pericarditis is diffuse ST segment elevation, as opposed to the more focal anatomic changes seen in myocardial ischemia. Lastly, ECG findings suggestive of cardiac tamponade include diffuse low voltages and electrical alternans. Hence the low alternating fence next to the tamponade night. Not sure what these descriptions mean? Fear not. Our corresponding videos for pericarditis and tamponade are coming right up. Obviously, whether you get labs or do other studies will depend on what you suspect might be going on. When you do get other tests, these are the most common ones for patients presenting with chest pain. First and foremost, if you're suspecting acute myocardial infarction, cardiac biomarkers would be at the top of your list of labs to order. Troponins are sensitive and specific, and they're the preferred test for diagnosis of acute myocardial infarction. At Sketchy, that means our recurring troponin T-bone steak. In the majority of cases, a single set of negative troponins is not sufficient to rule out MI, which is why we usually get at least two sets spaced 3 hours apart. For more details on the diagnosis of acute MI, check out our ACS sketch. Troponins are also elevated in most patients with stress induced cardiomyopathy. Yup, that is a truly broken heart with the cardiac markers to prove it. How about pulmonary embolism? It's a common and possibly life threatening etiology, but may be overlooked by emergency clinicians due to the wide variety of presenting signs and symptoms. In patients who lack a clear cardiac cause of chest pain, PE must remain on the differential. Patients with a high pretest probability of PE should go straight to imaging, with CT being the gold standard. This is why we've placed our recurring CT cat high in the well back there. D-dimer, on the other hand, is a helpful test for patients with a low pretest probability. Hence our recurring D-dimer symbol, scattered D-twigs. Head on over to our PE sketch for more details on the various scoring systems we can use to effectively rule in or rule out PE in the emergency setting, including the Wells and PERT criteria. A basic CBC, which is almost always obtained in real life, is only helpful in narrowing the broadest of differentials for chest pain. The white blood cell count may be elevated in any of the infectious or inflammatory etiologies of chest pain, including pneumonia, pericarditis, and mediastinitis in the setting of esophageal rupture. Besides blood testing, we often get imaging in patients presenting with chest pain, especially if there's suspicion for a cause other than ischemic heart disease. Chest x rays are most helpful in diagnosing pulmonary causes of chest pain, such as pneumonia, pneumothorax, and lung masses. Notably, PE is one condition that cannot be diagnosed this way. The vast majority of patients with PE have a normal or nonspecific chest x ray. Chest x ray may also reveal pleural effusion and mediastinal free air in the setting of esophageal perforation. Beyond the lungs, chest x rays can also help diagnose some cardiac causes of chest pain, such as a widened mediastinum in the case of aortic dissection or cardiomegaly and pulmonary edema in the case of heart failure, which can be seen during an MI. In any patient with chest pain and signs of shock, think tamponade or tension pneumothorax here, a bedside ultrasound should be performed. Additionally, in any patient with historical or clinical findings suggestive of tamponade, ultrasound is an ideal tool used to quickly make the diagnosis. A CT scan is ordered in the few cases when chest x ray isn't sensitive enough to rule out the condition. For instance, as we mentioned earlier, chest CT is the most widely used study for the diagnosis of PE. Furthermore, CT can also diagnose aortic dissection with high sensitivity, including in cases where the chest x ray may appear normal. Phew, is your chest hurting from all that information? Well, let's finish up with a recap of the differential diagnosis for chest pain, as well as a general outline for how to evaluate the many patients you'll see presenting with this chief complaint. The differential diagnosis for chest pain can be divided into life threatening and non life threatening causes. Make sure to evaluate and rule these six conditions out first, and quickly. The cardiac causes of chest pain that pose an immediate threat to life include acute coronary syndrome, aortic dissection, and cardiac tamponade. Classic symptoms of ischemic heart disease include chest pressure or discomfort in the center of the chest that's precipitated by exertion and relieved by rest. Chest pain that radiates to the left neck, jaw, or shoulder is a huge red flag. Acute coronary syndrome, which includes myocardial infarction and unstable angina, presents with these symptoms that are either worse or more progressive than the patient's baseline, such as angina at rest or symptoms that last longer than prior episodes. Aortic dissection is rare, but can be a truly emergent condition that's associated with high mortality. Patients with acute aortic dissection typically present with acute chest and back pain that is severe, sharp, and may have a ripping or tearing quality. Tamponade occurs when there's an accumulation of pericardial fluid under pressure, leading to significantly impaired cardiac filling and a clinical picture of cardiogenic shock that requires emergent intervention to reduce pericardial pressure. Patients with acute cardiac tamponade will present with hypotension, tachycardia, elevated JVP, and pulsus paradoxus. Life threatening causes of chest pain that originate from the lungs include pulmonary embolism and tension pneumothorax. The most common symptoms of PE include dyspnea and pleuritic chest pain, especially in the setting of a current or recent DVT or risk factors for one. A chest CT is the diagnostic test of choice if you have high suspicion for PE. While pneumothoraces aren't uncommon, tension pneumothorax is. Aside from chest pain, dyspnea, hypoxemia, and diminished or absent breath sounds on the affected side, which are common findings in all patients with pneumothorax, patients with tension pneumothorax will also have hypotension and tachycardia stemming from cardiac compression. The sixth and final life threatening cause of chest pain is mediastinitis, often caused, on the test at least, by esophageal perforation. Mortality for patients with mediastinitis is very high, rivaling that of aortic dissection. Patients presenting with esophageal perforation often have a recent history of repeated retching or vomiting, followed by acute onset of excruciating, sharp retrosternal chest pain, as opposed to the duller discomfort of ischemic heart disease. In addition, fever and leukocytosis are often present in patients with mediastinitis of any cause. Once you've ruled out those life threatening causes of chest pain, and the patient is hemodynamically stable, you can take your time working through the list of non life threatening causes of chest pain, which we'll fly through here. Make sure to check out our sketches dedicated to these conditions for much more information about the clinical presentations of them. The non life threatening cardiac causes of chest pain include stable angina, vasospastic angina, cardiomyopathy, and pericarditis that isn't severe enough to cause cardiac tamponade. On the lung side, a bunch of conditions can cause chest pain, including pneumonia, COPD, pleuritis, and pneumothorax that hasn't evolved to a tension pneumo. While esophageal perforation is a rare but life threatening GI cause of chest pain, GERD is one of the most common causes of non cardiac chest pain. Other, less common GI causes of chest pain include esophagitis, hiatal hernia, and diffuse esophageal spasm. Musculoskeletal etiologies are pretty common causes of chest pain. These include costochondritis, traumatic injury to the chest, and rib fractures. Alright, let's finish up with a recap of your evaluation of a patient presenting with chest pain. The history is where the majority of chest pain diagnoses are made, so make sure to spend time asking about every aspect of the patient's chest pain, including acuity of onset and duration of pain, the patient's description of what the chest pain feels like, where in the chest the pain is located and where it radiates to, as well as what, if anything, makes the pain worse or better. Asking about associated symptoms such as diaphoresis, dyspnea, and leg swelling in your review of systems can give you more clues into what might be going on. Don't forget about past medical and social history. While they may seem perfunctory or of little use, they're often the quickest way to make the diagnosis, since most patients commonly present with a condition related to something they've had or done before. When it comes to the physical exam, the first thing you have to do is look at the vital signs. Unstable vital signs, such as hypotension, need to be addressed before anything else. Only then can you go and conduct a thorough physical, examining not just the heart, but the lungs, soft tissue of the chest, and abdomen as well. Of course, virtually every patient presenting with chest pain gets an ECG. Check out our ECG how to sketch for everything you need to know to interpret the telltale ECG findings of acute coronary syndrome and other conditions that can cause chest pain. Lastly, use all the information you've obtained thus far to guide you in ordering other tests that might be useful, such as a white blood cell count, cardiac troponins, D dimer, chest x ray, CT, or ultrasound. Congratulations! You're now a pro at evaluating patients presenting with chest pain. One of the most common chief complaints you'll see in